Imagine, jumping on a trampoline or just laughing uncontrollably at a joke or even just sneezing forcefully and suddenly your body's plumbing completely betrays you.
Yeah, it's incredibly common.
Right. And for millions of people, this isn't some rare biological disease. It's actually a highly predictable structural failure.
Exactly. When the foundation of the pelvic floor shifts or weakens, the plumbing gets compromised.
But what if treating it was less about, complex medicine and more about just structural engineering?
That's exactly how we need to look at it.
Which is why today we're doing a deep dive into a stack of medical literature, clinical guidelines, and anatomical guides. We're on a mission to demystify a really effective non-surgical solution for this exact issue, stress urinary incontinence, or SUI.
Right.
Specifically, we are zooming in on the mechanical engineering of two devices, the incontinence dish pessary and the knobbed ring pessary.
They're fascinating little devices.
They really are. I mean, we're figuring out how a simple, precisely shaped piece of silicone acts as a mechanical backstop to solve a problem that forces so many people to alter their entire lifestyles. You're basically inserting a custom-designed structural support to instantly fix the plumbing.
And the physics behind it are incredibly elegant, honestly. Yeah. I mean, we spend so much time looking for complex medical or chemical interventions, but frequently, especially with the pelvic floor, we're just dealing with a mechanical failure of pressure and support.
Right, it's a physics problem.
Exactly. So to understand how these silicone devices work, we first have to understand the physics of the leak itself. Because the word stress, in stress urinary incontinence,
It has nothing to do with emotional anxiety.
right, nothing at all. It's entirely about physical, mechanical stress placed on the body's internal canister.
I want to break down that mechanical stress because I think a lot of people just assume, their bladder's getting old or it's just weak.
Sure.
What is actually happening physically when someone sneezes and leaks?
Well, let's visualize your torso as a closed cylinder.
Okay.
When you exert physical effort, like coughing, laughing, lifting a heavy box,
Or jumping.
right, jumping, your diaphragm violently pushes down and your abdominal muscles contract inward.
So the pressure goes up.
It spikes dramatically. All that internal force, that intra-abdominal pressure, has to go somewhere. So it shoots downward toward the pelvic floor.
And normally the body can handle that.
Seamlessly. A healthy pelvic anatomy handles it by distributing the pressure evenly.
Yeah.
But in SUI, there's a localized structural failure in how that pressure is managed at the very base of the system.
I'm struggling to picture how the fluid dynamics change just because of a pressure spike. Like, doesn't the sphincter still work? What exactly is failing structurally?
The clinical literature details a phenomenon called urethral hypermobility.
Hypermobility, okay.
Yeah, to put it simply, the base of the bladder and the urethra, the tube that carries urine out of the body, they physically descend from their normal, securely anchored position.
Oh, wow.
The sources heavily reference this widely accepted concept called the hammock theory.
Hammock theory.
Yeah, originally proposed by a researcher named Delancey. He mapped out how there's this suburethral hammock made of connective tissue and muscle.
Like an actual sling under there.
Right. It sits right under the urethra and is supposed to act like a firm, rigid backplate.
But I'm guessing that hammock doesn't stay taut forever.
Exactly. Well, to put a finer point on it, it sustains microscopic and macroscopic damage over time.
From what?
Factors like the immense mechanical strain of childbirth or pelvic surgeries or just chronic repetitive heavy lifting over decades.
Right.
That connective tissue hammock becomes incredibly lax. It sags significantly. And because of this laxity, the urethra drops out of its optimal position in the true pelvis. It literally sags downward.
Okay, let me see if I can map this out with an analogy, because I really want to understand the pressure dynamic you mentioned earlier.
Here for it.
Is this fluid dynamic shift similar to, like, trying to stop the flow of a garden hose by stepping on it?
That's a good start, yeah.
So, if the hose is lying flat on a hard concrete driveway and you step on it, the pressure of your foot easily pinches the rubber shut against the concrete, right? The water stops instantly.
Right.
But if that driveway somehow washes away and the hose is just suspended in midair over a ditch, stepping on it doesn't do much.
No, it would.
The hose just yields to the downward pressure of your foot and bends into the ditch. The water keeps flowing because there's nothing rigid underneath to pinch it against. Is that essentially what the hammock theory describes?
That captures the mechanics perfectly.
Yes.
Yeah. The urethra has lost its firm, backing your concrete driveway.
Wow.
And because that support is gone, the sudden abdominal pressure from a sneeze is transmitted unequally across the system.
So the bladder and urethra are feeling different pressure.
Exactly. The bladder is still positioned slightly higher up, so it takes the full brunt of that intra-abdominal pressure spike.
The pressure inside the bladder skyrockets.
Right. But the urethra has dropped into the ditch, so to speak.
I see.
Having dropped out of that primary pressure zone, the urethra doesn't get the same squeezing force applied to it from the outside. So the pressure inside the bladder drastically exceeds the resistance pressure of the urethra.
And fluid always follows the path of least resistance.
Exactly. The sphincter is simply overpowered, resulting in an involuntary leak. It is fundamentally a failure of pressure transmission, not necessarily a broken sphincter.
Okay, well, if this is purely a mechanical failure of pressure and missing support, it stands to reason there must be a purely mechanical way to rebuild that concrete driveway without, immediately resorting to surgery.
That is the exact gap in the anatomy that incontinence pessaries are engineered to fill.
When you dive into the clinical sources, the diagrams of these devices are fascinating.
They really are.
We aren't just talking about standard, basic supportive pessaries, which are often just simple silicone rings used to generally prop things up.
No, these are very specialized.
Right. The literature highlights two specific devices for this: the knobbed ring pessary and the incontinence dish pessary. And unlike standard models, these feature a very distinct solid bump on the front edge of the silicone.
Yes, the knob. It's a marvel of focused biomechanical engineering.
How so?
Well, to understand its role, we have to look at the geometry of the pelvis. When an incontinence pessary is properly inserted, that specific knob sits directly beneath the urethra and the bladder neck.
Also known as the urethrovesical junction, right?
Exactly. And by occupying that highly specific localized space, it mechanically elevates and elongates the urethrovesical angle, the angle formed where the bladder meets the urethra.
I have to ask, on behalf of anyone listening who is trying to visualize this internally,
Sure.
if there is a solid silicone bump wedged right up against the urethra, restoring that driveway, isn't it just tightly clamping the hose shut 24/7?
It seems like it would, right?
Yeah. Like, how would someone even go to the bathroom normally if there's a constant physical block pressing on the tube?
That is a crucial functional distinction we need to make. The knob is not cutting off normal urination because it provides dynamic resistance, not static compression.
Dynamic resistance. Okay.
When the user is just going about a normal day, sitting, walking, resting the knob, it's simply resting in place. It's providing gentle support and restoring the proper anatomical angle. It's not squeezing the tube shut.
So it only acts as a clamp when the pressure spikes.
That's the brilliance of the design. When that sudden intra-abdominal pressure from a sneeze or a cough hits, the bladder is pushed violently downward by the internal force.
Right.
And the urethra is suddenly compressed right between that downward pressure spike and the rigid silicone knob.
Oh, wow.
And the knob itself is backed up against the symphysis pubis, which is the pubic bone.
Oh, I see. So the pubic bone acts as the ultimate unmoving backboard.
Yes.
The silicone knob serves as the new concrete driveway, and the pressure from the sneeze acts as the foot stepping on the hose.
You've got it perfectly. Because the knob is resting securely against the unyielding pubic bone, the urethra is pinched shut for the exact millisecond that the pressure spike occurred.
Stopping the leak entirely.
Entirely. It essentially restores the equal distribution of pressure that the body's natural, undamaged connective tissue used to handle.
And then what happens right after the sneeze?
The moment the cough or sneeze is over, the intra-abdominal pressure equalizes, the downward force lifts, and normal voiding is perfectly possible again because the clamp releases.
It's completely passive until the exact microsecond it needs to be active.
Exactly.
That is incredibly clever engineering. But looking at the two primary shapes in the literature, the knobbed folding ring and the incontinence dish, they look very different structurally, even though they both feature this knob.
They do look different, yes.
Why would a medical professional fit a patient for a ring versus a dish?
The choice comes down to the complex reality of pelvic floor disorders. They rarely happen in isolation.
Meaning, there's usually more than one thing wrong.
Exactly. Taking a step back to look at the broader anatomical picture, many patients experiencing stress urinary incontinence are simultaneously dealing with some degree of pelvic organ prolapse.
Right. That's where organs like the bladder, uterus, or rectum lose their support and physically descend into the vaginal canal.
Yes. The structural failure usually affects multiple systems. So the ring with knob is specifically designed for someone dealing with both of these issues at the same time.
SUI and prolapse.
Right. It looks just like a standard ring pessary, but with that prominent bump we've been discussing. According to the clinical guidelines, adding that knob actually adds to the overall diameter of the pessary.
How big are they?
These devices generally range from 55 to 90 millimeters in size, so roughly 2 to 3.5 inches across.
Okay.
The wide ring portion provides broad outward structural support to keep the descending uterus or bladder elevated, while that specific knob is positioned carefully behind the pubic bone to support the urethra.
But then you have the dish pessary. Instead of an open ring, it's a circular, cupped, shallow bowl. It almost looks like a tiny saucer with a bump on the rim.
The bowl shape of the incontinence dish serves a very specific structural purpose. It is particularly effective for supporting a large anterior prolapse.
An anterior prolapse. Let's define that. The sources mention a cystocele. Is that when the bladder itself drops forward?
Essentially, yes.
Mm-hmm.
In a cystocele, the connective tissue between the bladder and the vagina weakens, and the bladder drops, pressing heavily into the front wall of the vaginal canal.
Ouch. So how does the dish help that?
The solid cupped dish shape acts almost like a physical shelf to scoop up and comfortably hold that dropping bladder.
Oh, like a cradle.
Exactly.
Oh.
All the while, the knob on the rim is simultaneously addressing the incontinence by bracing the urethra.
That makes total sense.
The clinical literature actually notes that the dish design can be highly effective in cases where a standard open ring pessary has failed to provide enough surface area to support a severe prolapse.
Okay, so form truly follows function, and you need different tools for different structural collapses.
Very much so.
But reading through these clinical guidelines, there was a statistic that genuinely caught me off guard.
That's fine.
The sources point out that up to 50% of the time, pessaries can displace or rotate because they lack a stable anchor point.
Yes, that is a huge issue.
Right, because if you're scooping up a dropped bladder and fighting the downward force of a cough, how does this thing not just fly out? If that knob rotates even slightly away from the urethra, the whole system fails.
The anchoring problem is one of the biggest challenges in pelvic biomechanics.
I can imagine.
You can't just put a smooth silicone device into a flexible, muscular, lubricated tube and expect it to stay perfectly still under immense abdominal pressure without some very clever geometry.
Right.
The most effective pessary designs don't just push upward, they direct their physical pressure outward, laterally, toward the sidewalls of the vaginal canal.
Why rely on the sidewall specifically?
Because of the anatomy that lies directly behind those sidewalls. If a device puts too much pressure on the anterior wall in the front or the posterior wall in the back, it is pushing against soft tissue.
Pushing into the bladder or the rectum?
Exactly. Not only can that cause significant discomfort or tissue damage over time, but soft tissue simply yields. It's like trying to anchor a heavy rock climbing hook into mud.
That's a great visual.
But the sidewalls are entirely different. They are directly supported by the rigid architecture of the pelvic bones.
Ah, the sources mention the ischial spines here.
Yes.
For those of us without an anatomy chart handy, what are those?
Think of the ischial spines as two little bony ledges located deep inside the pelvis on either side of the vaginal canal.
Okay, bony ledges.
By forcing the pessary's outward pressure distribution specifically toward those laterally supported sidewalls, the device wedges itself against a rock-solid foundation.
Oh, wow.
This lateral tension creates a highly secure resting point. It significantly lowers the chance of the device dislodging or rotating out of alignment.
Ensuring that the knob stays locked exactly where it needs to be.
Right behind the pubic bone, directly under the urethra.
So it's utilizing the skeleton itself as a scaffold?
It is.
Which makes me wonder about the day-to-day reality for the user. Because this anchor relies on such specific bone structures and exact angles, I imagine placing it isn't as simple as inserting a tampon.
No, it's not.
How do you actually get it positioned perfectly behind the pubic bone and wedged against those bony ledges?
The geometry of placement is a careful puzzle. The clinical guides give very specific instructions on the mechanics of fitting, and it requires a deliberate technique to navigate the internal anatomy correctly.
Let's walk through that because it demystifies the process for you. First, the user compresses or folds the silicone pessary in half.
Right.
Then, the edge opposite the knob is inserted first. The guidelines say to direct it deep toward the posterior fornix.
Yes.
To translate that clinically, the posterior fornix is the deepest pocket at the very back of the vaginal canal, almost like a cul-de-sac tucked behind the cervix.
That deep placement is critical. By getting the back edge into that posterior cul-de-sac, it establishes the first anchor point.
Once that back edge is anchored deep inside, the user has to physically rotate or pivot the device upward in the vagina so that the front edge, the part with the knob, swings up and locks into place right behind the pubic bone.
Exactly.
And removing it requires just as much specific geometry. You can't just pull on a string.
No, absolutely not.
The devices feature a large hole directly under the knob. The user has to hook a finger into that specific hole to break the natural section that forms and gently ease the knob down and out from behind the bone.
It is a very deliberate anatomical maneuver. It ensures that once the device is seated, it bridges that structural gap flawlessly.
Right.
And the precision of that fit is why the outcomes are frequently so immediate and dramatic.
Dramatic is absolutely the right word. There's a quote from one of the clinical sources we reviewed that just stopped me in my tracks.
The one about leaving the office?
Yes. It's a medical professional discussing their experience fitting patients with the incontinence dish. They reported that because of this precise mechanical fit, some patients have actually left the office dry.
It is one of the most profound, immediate interventions in pelvic medicine.
I bet.
The patient isn't waiting 6 weeks for a pharmaceutical medication to build up in their system or enduring months of painful recovery from invasive sling surgery.
Wow.
By providing that backboard, you are instantly restoring the mechanical integrity of the pelvic space.
I want to talk about the long-term impact on the body, though. The sources use an analogy that really stuck with me.
Okay.
They compare using an incontinence pessary to wearing a knee guard for a ligament issue.
Yes.
That made me wonder, is this just a passive crutch? Like if you wear a knee brace too long, sometimes your leg muscles actually get weaker because they stop doing the work.
Right, they atrophy.
Are we just bypassing the pelvic floor muscles entirely with this silicone plug, or are we somehow helping them?
That is a brilliant question. And the literature reveals a profound neuromuscular benefit that goes way beyond a simple crutch.
Oh, really?
It is absolutely not just a passive plug. Think about what happens internally when organs prolapse and the hammock sags.
Okay.
The pelvic floor muscles are supposed to be a dynamic, resilient support system. But when everything drops, those muscles are forced into a constantly overstretched, mechanically disadvantaged state.
They're essentially exhausted 24/7.
Completely fatigued. They are perpetually working overtime, straining endlessly just to provide minimal support against gravity.
Wow.
But by mechanically lifting and supporting the bladder neck and the descending organs, the pessary removes that crushing, constant physical burden.
It takes the weight off.
Right. It physically returns these overworked muscles to their normal anatomical resting position.
Why does getting them back to their resting position matter so much for rehabilitation?
It comes down to a fundamental concept in muscle physiology known as the length-tension relationship.
Length-tension relationship.
Yes. Every muscle in your body is made of tiny fibers that slide together to create a contraction. If a muscle is stretched way beyond its normal length, like a rubber band pulled to its absolute breaking point, those fibers can barely grip each other.
Oh, I see.
The muscle physically cannot contract effectively. It loses all its power.
Right.
By reducing that excessive chronic stretch, the pessary restores the optimal length-tension relationship. For the first time, perhaps in years, the pelvic floor muscle is sitting in a shortened, relaxed position where it can actually generate a powerful, effective contraction again.
That makes total sense.
Yeah.
You aren't replacing the muscle's job. You're giving the muscle the slack it needs to actually work. It gives the rubber band its snapback.
To put it another way, it transforms a futile muscular effort into a productive one.
So physical therapy could actually work again.
Exactly. When a patient with a properly fitted pessary does their pelvic floor physical therapy or Kegel exercises, they're actually getting a return on their investment. The muscle is finally starting from the correct biomechanical position, allowing it to build real strength over time.
The silicone device acts as the temporary concrete driveway, instantly stopping the leaks, while simultaneously giving the surrounding muscles a fighting chance to rebuild the natural driveway.
It is a remarkable synergy of external mechanical support and internal neuromuscular rehabilitation.
Whether you are dealing with stress, urinary incontinence yourself, or you know someone who is, and given the statistics, you almost certainly know someone who is quietly managing this, understanding the actual physics at play, is incredibly empowering.
It really is.
We are talking about a condition that forces people to stop exercising, stop laughing freely, and completely map out their daily lives based on the nearest restroom out of fear of leaking.
It takes a huge psychological toll.
But to know that a simple, non-surgical piece of soft silicone can instantly restore the pelvic floor's physics, acting as a dynamic anvil against the pubic bone to stop leaks, completely changes the narrative.
That's
It proves this isn't some shameful failure of your body, it's just a structural shifting that can be logically and mechanically supported.
It removes the stigma entirely. It moves the conversation from something embarrassing to a straightforward physics problem with a highly effective, elegantly engineered solution.
Which brings me to a final, slightly mind-bending thought I want to leave you with, based on a tiny detail buried in these clinical sources.
Mm.
Today, we've been talking about static silicone pessaries that hold their shape, fold to go in, and then rely on their molded geometry to compress the urethra. But the sources also briefly mention inflatable pessaries.
Yes, devices with actual hollow stems and external hand pumps.
They have these little stems with a bead and a manual hand pump that allows the user to inflate them with air or fluid once they are already inside the body, expanding to occupy the space perfectly.
It's wild to think about.
So, think about this. If a static, unchanging piece of silicone can cure incontinence by meticulously manipulating the urethrovesical angle and providing a backboard, could the future of pelvic health be dynamic, shape-shifting devices?
That would be revolutionary.
Imagine a pessary you could manually inflate for maximum rigid support right before you run a marathon or jump on a trampoline, and then deflate a bit for softer comfort when you're just sitting at your desk all day.
Customizable biomechanics.
A truly adjustable, real-time foundation for your body's plumbing that changes as your activity level changes. Something for you to think about until our next deep dive.